community nurse or who a community nurse is and their job description. I know we both all had hospital-based training and clinics, and this is your first time coming to Qatar, and this is the first time that you are going to be working in the community. So it is very important that you understand what community nursing is all about, your job description as a community nurse, and what does it really means when we tell you that now we are going to be nurses that will be working with PNS. That is the private nursing services for HMC. Number one, community nursing involves what? Delivering high quality care with the people of the community. That is one-on-one care with families or with a member of a family. Two, community nursing involves you taking care of maybe people that are working at an industrial site. They might be doing some construction, they might be doing some road work, and you are the community nurse that is a standby in case of an emergency. Equally, a community nurse can equally be working where? In schools, as well as generally as someone that is, if you are a case manager that you're working with the community, then you'll be going to the community and checking on what other nurses that are working with the patient are doing. This is you having workplace, home, schools, and industrial side focus, and you will be looked upon as a community nurse. Unlike where we came from, which was hospital-based. We were caring for patients in the hospital, and we probably had a large number of patients that we were caring for. You had 5:1, 4:1. For me, in Africa, there is no 5:1. There is surely a generation is the one, because we might have 2 nurses on duty for a night duty, and we have 50 patients. So what should I put? Ratio of 1:25. So you see, there's a big difference. Unlike if you're working in the community and you're working specifically for a patient at home, then you will be a 1 nurse to a 1 patient. There is no opportunity here for you to be a nurse working with numerous patients. No, only 1 nurse and a 1 patient. If you're working for a school, there will be the general lookout that you will be doing in the school as giving health education, healthy lifestyle, checking the hygiene of the people or the students or the university students or whoever the school or what school setting it is. If it is a special needs school, then you will have probably more work because all the students will equally need special attention. And for some schools, there will be particular individuals in school that are probably suffering from diabetes, hypertension, or whatsoever, depending on the level. If you are with children, if you are in a primary school, then we'll be having, most of the children that are suffering from diabetes will be having type 1 diabetes, that is inborn, a malformation. And this is going to give you what? That attention that you know, even though I am working for the whole school, there is a particular student in this class that has this particular problem. So I must make sure that I take care of the student in a specified way. There will be students who will be able to give insulin on time. There will be students that you need to check time by time because they might have episodes of epilepsy. Okay, there might be students in class that have what? There might be students in class that are suffering from sickle cell, and you equally need to check on them time to time. And for the industrial sites, in the construction or road construction, whatsoever it might be, you will be giving them a lifestyle on how they need to drink water, keep hydrated, on education about stress and good body hygiene after work, and you'll be making sure that their BP and every other thing is in check so they don't go and collapse where they are not supposed to. Okay, just imagine they are excavating something from the road and there's somebody that just falls in. That would be one way, one ticket to heaven. Okay, so you will make sure that you give them this health education, and in case there is any occurrence of an incident at the site, because you are already a standby health personnel that is there, you'll be able to manage the situation first aid, and then second, transfer to the health facility. Next, in Qatar, because we are community nurses, we are working with what? We are working with HMC and PNs, that is the private nursing services for HMC. And what are we doing? We are primarily having access to patients that have chronic conditions that needs one-on-one care at home. So these patients is their patient. The hospital cannot accommodate everybody at the same time, and therefore the hospital will allow some of the patients to go home. But would they just go home, they will need a nurse to go with them. And this is where you come in. You will now be sent with the patient to go home, and they will still have the faith that you will be able to take care of this patient at home as though they were in the hospital. And that is why all the HMC nurses, be it hospital-based or be it for private nursing services, you must be a registered nurse and you must be licensed in Qatar before you are deployed to work. Next, we now look at the overview of what? The healthcare system in Qatar. You were in India, you have the way your healthcare system is. You have how you have to take your license, where you have to take your license, and the practices generally that you do. But now when you come to Qatar, we will be talking about what? We'll be talking about Ministry of Public Health that govern both the public and the private sector. And if without you being licensed by the Ministry of Public Health, you cannot practice in Qatar. Next, you will equally what? You are focused on the healthcare excellence system. I tell you, there is a difference between offering nursing services and offering quality nursing services. And the only services that we offer is quality nursing services, making sure that what we are promoting and we are assisting our patients to live a better, a happy, and a good life until their dying day. What is the role of the nurse as a community health worker? For PNS, one, for community nurses, their key role is to promote health first. And when we are talking about promoting health, what is a good example of a nurse that is working in health promotion? You have to speak the same way I'm speaking.
We can educate the patient.
Education. When you are educating the patient on a lifestyle, when you are helping the patient to maintain and to have a good relationship with sugar, because it is an addiction here in Qatar that everybody is suffering from. When you are helping the patient to go to exercise, when you are helping the patient to eat in good quantities and frequently and not starve themselves for a long time, when you are educating the patient on sleep and rest, limiting stress, you are doing what? You are promoting the health of that patient. Now, next we'll be looking at preventing diseases. In which scenarios are you going to be playing a part in preventing diseases?
Communicable diseases.
Sorry?
Communicable diseases, that means you can educate them to.
Let's say in a situation that we look at COVID-19 and we talked about safety, we talked about hand hygiene, we talked about infection prevention and control. You will be preventing diseases, because if you left from the community, if you left your accommodation and you have somehow touched any of the surfaces and anything that is not good, because you don't just leave the accommodation and you appear in the patient's accommodation, you will go by transportation. And this transportation, you are not the only one sharing. There are other nurses that will be carried alongside with you that equally have been exposed to one or two things. So when you make sure that you respect safety, when you make sure that you are doing prevention by doing effective hand hygiene, and all what has to do with infection prevention and control, when you are making sure that your patient does not overfeed, does not take a lot of junk food, you are simply trying to do what? Prevent diseases. Because now we'll be talking of sugar, now we'll be talking of obesity, now we'll be talking of other disease conditions that will come as a result of lifestyle that they are living. Next, managing chronic disease conditions. Which are some examples of disease conditions that we'll be managing in patients' home? Like dementia patient, yes, what else?
Palliative care.
Palliative care, yes, we'll be giving palliative care, but which disease conditions are those disease conditions that are chronic that we will be managing?
Chronic disease.
Like, that is what I want to know.
Like diabetes.
Like diabetes, good example, what else?
Hypertension.
Correct. So there are so many disease conditions we'll be looking at here. We're looking at obesity, we're looking at diabetes, we're looking at hypertension, we're looking at kidney failure, we're looking at urinary tract infection, we're looking at patients that are completely bedridden, we're looking at patients with COPD that have are completely on mechanical ventilation. Those are chronic disease conditions that we will be exposed to that we need to handle. As well as PNS in Qatar often focuses on outreach, health, home health services, maternity and child health, management of non-communicable diseases like diabetes and hypertension. Next, what will be your scope of service? Your scope of service will be to what? Health promotion and education, to management of chronic diseases. We have obesity, we have hypertension, we have asthma, we have COPD, we have monitoring, education, and support. As well as we will equally be doing what? Lifestyle. Mostly the education we'll be talking about is nutrition. We talk about lifestyle. We're talking about smoking cessation. We'll be talking about mental health, which probably is always the last thing that everyone is looking for. Because come on, we already know that this individual is healthy. If illness or a disease is not that which we can see that a leg is cut, a hand is bent, or an eye has been blocked, or the individual is bedridden, we don't just realize that they could be healthy individuals that are moving, but their mental health is shattered. So we always have to look at that aspect. And when we look at maternity and child health, this is a perfect example that we'll be talking about health promotion and disease prevention. Because when we talk about maternity health, this is a nurse that is going to take care of a pregnant woman, making sure that her lifestyle is okay. She eats, she clothes, she bathes, her hygiene, her cravings, and every other thing is met. Making sure that she does not develop any disease condition like what? Which are the disease conditions you can develop as a result of pregnancy? Gestational hypertension or gestational diabetes. And when you are able to control that, you are preventing a disease condition from occurring. Next, we'll be looking at the maternity period, the period that she is now ready to deliver. She will be there to support, to give emotional, physical, and whatsoever support that is needed for this woman to go through the period of delivery. And after delivery, she will now be doing what? Making sure that she cares for the child. And here, we'll be looking at immunization schedule. She will be programming all the immunization schedule for the child as detecting any disease condition or malformation. There are children that are born normal, they are born okay, everything checked, all reflexes done, they cry, they do every other thing like any other child. But when they are already 6 months and above, we now start seeing certain malformations that will develop. So this individual is going to be able to manage this. And we'll be looking here at the pediatric nurses and the maternity or the, what do they call them? The midwives. So if we have a midwife, This is the care that we will be sending this midwife to. If we have a pediatric nurse, this is who we are going to be giving. For you and I, we are adult nurses, so we're taking care of adult or patients that are on palliative care. Now it comes to adult care, where we perfectly fit in. This is our specialty. And for adult care, we'll be looking at the promotion of health, what managing chronic diseases, which we will be focusing on what mobility and ensuring a good quality of life. This individual has lived their life, they have gone through their period of growth, they have gone through their period of everything that you can ever think of. Now they are at their period of rest. They just want to live a good life, a healthy, a happy life. And you will come in here to make sure that we talk about ambulation, we talk about medication administration, we'll talk about balancing, turning of the patient in and out. Maybe the patient is having a catheter, you're talking about a COTI. Maybe the patient is on oxygen, we're talking, maybe there is a tracheostomy. All of these will now be the changes of lifestyle that the elderly will have, that you will now come to play a part in. And this part might not necessarily mean that we are moving towards a curative end. We might just be making sure that we are taking care of the father in their last days, so they die a happy and a fulfilled life. So I don't want the nurse that when you go on duty, your face cannot even make the patient smile. I should see a happy patient simply because you're on duty. Because this is their last moment. They want to live it happy. They want every step of the way to be an impact. Because they have nothing to lose. They are not going to leave that house again to go wash a match, or leave that house again to go to a restaurant to eat, or leave their bed to go to a park to have fun. You are the only one that will be there 24/7. Their children might only come during weekend. So I am expecting to have a kind, an attentiveness that is able to give the emotional, physical, mental support that their patient needs to be able to move to their next step in life. Be it palliative, be it management of chronic diseases. Emergency preparedness and disaster management. Now, when we talk about emergency preparedness, what are we looking at? We are looking at those scenarios where your patient has a crisis. How do you manage a scenario that there is a crisis? How do you manage a scenario in case you are at home and your patient suddenly develops difficulties in breathing and start losing consciousness? How do you manage a scenario when you come to realize that in the morning as you're doing physical assessment, you could identify that there is pulmonary edema? How do you manage a scenario of a case where you find that there is a heart attack, there is a development of a stroke? What will you do? How do you manage a scenario where there is a fire incident? I told you the categories of patients yesterday, and those categories of patients will help you on when you want to look at evacuation. Because we are taking evacuation from the highest critical, who are unable to move, to the least who can move by themselves. And when we are looking at the emergency preparedness, one, the collaboration of the nurses with other community workers and with other healthcare professionals. This is you collaborating with me. This is you collaborating with the home care office. This is you collaborating with the pharmacy. This is you collaborating with the instrument office. This is you collaborating with the physician and the case manager for that patient. All of these people are only going to come to play when you are able to do an effective job. The pharmacy will only come to play when you indicate to the pharmacy that I have an expired medication and I need a refill. I have a medication that is finished and I need a refill. The pharmacy will only come to play when you realize that you ordered for a suspension and you were given a capsule. You will now call the pharmacy to indicate that there was a medication, a supply reason for a capsule, and to get the right prescription from the pharmacy. The physician will come to play. If you identify that there is something wrong with your patient and you are calling for help, the wound care nurse will come into play when you identify that there is a wound, there is a vessel, there are bruises, and you need them to give you the protocol and to train you on what to do. Do you understand? So you are actively the main individual that is with the patient, that is doing your day-to-day assessment, and to identify if there is any need for this collaboration. So I should not call, one day you tell me in your report that this morning upon assessment, you identify that there is a bruise, or you identify that there is a development of a vessel in its first stage, and you are unable to call the wound care nurse. That is a lack on your side. There shouldn't be a scenario where the family calls me to say you administer an expired medication. You are the nurse, you should be checking all these things. And this collaboration does not end only with the healthcare personnel, but with the family and your care partner. Because you would be having a care partner that is either from the family, you meet that there was already someone taking care of Baba, maybe a nurse or a healthcare assistant. You are now coming to work hand in glove with that individual. And in case there is no care partner, because maybe a daughter, a son has been doing that job, you will be working in collaboration with them. Next, emergency number. The only emergency number we have in Qatar is 999. You should never forget that. Even if you are awoken from sleep, you should be able to identify the emergency number. Not just for the patient, but for yourself. Something can happen to you. And someone comes. So what do we do now? You just ask them to call 999. 999 will be able to come and will be able to arrest or solve the situation. Next, communication with your supervisor. I am your first line of communication when it comes to administrative and any other thing that involves. Let's say you received your salary and maybe there was a scenario you had to do overtime at some point and something happened and there is a problem with your salary. I should be the first person you call and ask about it. And I will escalate it to the management and to the HR and they will take it from there. If you want to say have a problem and you need to talk with the head of nurse education, you communicate with me, I will talk with her, and if something she just needs to respond to you, she will respond to me and I'll get back to you. If she needs to talk to you, I will indicate to you to talk with her directly. Is that okay? If not, I am your first line of communication, whether it's when you just feel like you are not okay, you are not fine, something is wrong, you are now having a culture shock in Qatar, you don't just feel like communicating anything at all. You are certainly free to talk to me at any time, right up to 12 midnight. That is when I don't take any calls from any guest because I too will be sleeping. However, if there is a scenario that has happened in the middle of the night because you were doing night duty, you can certainly call me directly because this is you trying to wake someone that is sleeping. If you send a message, my phone will not be in reach with me at that moment. It means I will see it in the morning. Is that understood? Okay. These are my information. You have my number. You have my email address, which you certainly can write me and send me an email. In case you want to take emergency leave, in case you want to take a sick leave, in case there was a scenario or there is a complaint you want to make, you must send that complaint officially through my email. If you just want to make a communication, you can always communicate calls or you send a WhatsApp message. And if I see that it's something that you need to send me an official email, I will indicate that you sent it again through an official email. Is that understood? But this is the addresses that you can use. Next, communication with the family. One of the most important aspects of your care is to make sure that the family understands exactly what is happening with their loved one at all times. So if you want to do handover, say you are doing a 12 or 6 service, you're handing over to your patient, to your care partner, let one family member be there. In case where you are in a household where the family members are not living there, make sure that the family has given the permission that their care partner is okay to take services without them being involved. Is that understood? So they should not be lost at some point and wondering what happened or what is happening with their loved one. They should know. If you have to order for medications, if you have to collect medications, if you have to collect maybe supplies, accessories for the patient, do that in collaboration with the family. Now, service hours. You want to know what are the service hours that we have here in PNS. We have, first off, we have 4 different types of services that is being offered. The first is the 24/7 service. For the 24/7 service, what does it mean? It means you work for 24 hours for 7 days. And for the 24/7 service, 2 nurses are provided. One will be working morning shift and the other will be working night shift. And on the days that they are off, there will be 1 reliever or 2 relievers. What happens when there is 1 reliever? If there is 1 reliever, because our off days is always Friday or Saturday, on Friday in the morning, the morning duty nurse for that day will go off, and the reliever will be working with the night nurse. On Saturday, the night duty nurse will be going off, and the reliever will be working night with the morning duty nurse. Is that understood? For a scenario where they have 2 relievers, the 2 relievers will be relieving the nurses on the same day. It means the 2 primary nurses will be off and the 2 relievers will work that day. So that is the first service. The second service that we offer is a 24/6. And for the 24/6, it means we are working for 24 hours for 6 days and 1 day we are off. And for this 24/6, there are 2 primary nurses that are provided for that patient. They will either have off on Friday or on Saturday, depending on when the family has decided for them to have off. Next service is a 12/7. For a 12/7, there is 1 primary nurse and 1 reliever, and they will be working 12 hours. The primary nurse will be working 12 hours for 6 days. The day she is off, the reliever will work. The next service is a 24/6, and for a 24/6, we have 1 primary nurse working for 6 days, 12 hours per day, and the family will choose if they will be off on Friday or on a Saturday. And just so you understand it, if you are working a 24/7 or a 24/6, I will be able to change the timings that you're working. It means for this month, 1 nurse will do morning and the other nurse will do night. And the next month, I will change. The one that is doing night will do morning, and the one that is doing morning will do night. This is when there are 2 services for 1 patient. However, when we are doing 24/7, the family is the one to choose when they are most needed of a nurse. It means if they said you are working night, it means that they already have provisions for somebody to work by morning, and the time that they really need a trained nurse is by night. That way, there is nothing I can do to help you. When you start complaining of the fact that you have headache, you have hand brace, you have this, because what am I supposed to do? The service is only 12 hours, and the family has chosen when they want you the most. It means you are a night nurse. And if you're a night nurse, you must find it possible to sleep by day without being affected with the fact that you're working by night. So by night, you work all night, and when you get home, you have your shower, you eat, and you sleep by day as though it was your night. So if you normally sleep 4 hours in the night, I need you to sleep those same 4 hours by day. If you normally sleep 6 hours or 8 hours by night, you should find enough time to sleep those 6 hours or 4 hours by day. That way you balance it up. But if you go for night duty and then you come back and you can't sleep by day, it means that you will neither be productive by day or by night. And I don't want that. And remember, there is nothing I can do except the family decide to change you from a night to a morning duty. And when we already submit your document as the primary nurse for that patient, I cannot just remove you from that patient and send you to a morning duty somewhere else and remove that individual to send to you. You are that patient's nurse. I cannot change it. Except the family wants a change of nurse, they will go to PNS and indicate that they want a change of nurse. PNS will come back to us and say, the family do not want you anymore. If not, there is nothing I can do. I am insisting on this because if you happen to be given a 12-on-7 or a 12-on-6 duty and you're working night, remember today that I will remind you of the fact when you start complaining that, Mom, I have headache because I cannot sleep by day, I will tell you there is nothing I can do. Next, a 12-on-6 hours or a 12-on-7, if the patient decides that you will be a morning duty nurse, you cannot as well tell me I am tired of getting up in the morning by 6, because maybe your duty is 6:30, maybe your duty is 7, or maybe your duty is 6. Like in the case of Prima, you cannot tell me that my duty is 6, so I am tired of getting up at 5:30. Please, can I now work night at some point? I can't change it. I am not the author of changing when you should get up and when you should not get up. The highest I can do is talk with the family. If they need to have any switch, if the family is comfortable and wants you at that time, you will work that time. Okay? So your mental health is what I need you to adjust. You need to adjust to the fact that if you're working morning and it is a 12-on-6, you are working morning. There is no change on that, except the services is upgraded and they don't give them a 24-on-7 that I can switch you. If you are working a 12-on-6, that is a night duty, you are a night duty nurse and you must find a way to sleep by day. Is that understood?
Yes.
Okay. Next, we are working for 12 hours, either morning or night duty, and you know already that you'll be provided with accommodation and transportation, and equally, you already have your uniforms. This is your official wear that you are supposed to use to go for duty. HMC standards of care. What is the standard of care for HMC? HMC is, they provide what? Number one, they provide holistic care to their patient. High quality, holistic care, not just nursing service. If I come in and I give my patient medication, I give them food to eat, or I serve them with food to eat, and I make sure they drink water and do every other thing, that is nursing care, which can be provided by a nurse assistant, which can be provided by a caregiver, which can be provided by a family. But the high quality care is what they are now putting you as a state registered licensed nurse to go and provide to this individual, without discriminating whether they are old, young, rich, or poor, without discriminating whether they are children of special needs or they are healthy individuals. Making sure that you are looking into their care, not just physically, not just spiritually, but what? Mentally, psychologically. Making sure that they are not just looking well physically, but their mental health is well. Making sure that the family is confident enough that the nurse that has been given to take care of mama, or the nurse that has been given to take care of baba, is capable of being a companion, a friend, and a nurse to their father, or to their mother, or to their child. Is that understood? Next, you must respect all 5 competencies. Do you know the 5 competencies? You will get to it. And now the 5 core competency is what you are going to take over with Ma'am Patricia. And this 5 competency is what you are going to be doing for your competency exams. As well as this 5 core competency is what you are going to be practicing every day to the last day that you are going to study. Next, you must follow all policies and guidelines as though your life depends on it. Because you are going to have a lot of documentation. That is the difference between you and a caregiver and a nurse assistant. They don't have to document anything. They just do whatever they do and off they go. You have to document each and everything you do, because without documentation, it was never done. And when they start you with training for your documentation, make sure you take every note for every clause. Make sure you understand every step and what and where and when you are supposed to do what. Because unlike as we are talking here, you are going to go into practice and then you start having problems of why you have a lot of documentation to do. You have a lot of documentation because you're a nurse. Okay? So you must follow each and every policy when it comes to documentation. Now we have our 5 core competencies. As nurses, be it in Qatar, be it in your home country, in India, be it in the Philippines, be it in Sri Lanka, be it in Kenya, be it in Cameroon, be it in Nigeria, be it in whichever country. As nurses, our basis for practice lies on these 5 core competencies. Number 1, we will be looking at physical assessment. Number 2, we'll be looking at pain assessment, management, and reassessment. Number 3, we'll be looking at communication via ISPA. Number 4, we'll be looking at what? Infection prevention and control, as well as number 5, we'll be looking at medication administration and management. This is what your competency exam will all be about. You will be tested. If you make it through, you'll be given a patient, and you will practice each and every one of these every day of your life. Is that understood?
Yes, ma'am.
Are you done talking?
Yes.
Okay. So whatever you do, however you do it, you should never forget any of these steps, because you need all the steps each day in your practice. And this is the guidelines and the policies PNS is expecting that each and every nurse that works for them should know. Now, the 5 core competencies holds the key to your staying in Qatar. If you pass the competency exams, you'll be given a patient. If you fail the competency exams for 2 chances, you are given only 2 chances. It means the first chance you fail, you'll be given a second chance. If you fail for the second chance, you are on your own. The administration will decide what to do with you, because at that level you cannot work with me again. That is when our relationship has finished. So the administration will decide if they will be sending you off to the clinics or to the hospitals or whatsoever, but you cannot work with PNS, with patients at home. You will be wondering why you should be going through a strict examination. Why, if you were just going to the hospital, you will not go through this? I will tell you. Because when you are a nurse and you're working in the hospital, you have the doctors, you have the specialists, you have your team, you have everyone working with you. It means that the whole team that you will be able to call. It's already with you. You simply just need to click code blue, code red, code pink. All the codes are available. You just need to shout out and everyone will be there. But when you are at home with the patient, you will need to assess this patient by yourself. You will need to identify what is wrong with the patient. If the situation is improving, it's not improving by yourself. You will be the one to call the hospital or the emergency line to indicate what is wrong with you and your patient at home so they can come. So you can be referred to the hospital. They need a nurse that is competent enough, that understands the basis of nursing and medicine to be able to identify when something is going wrong and call for that emergency line. To be able to handle their patient and manage their patient without direct supervision. Because those in the hospital are under direct supervision. We go in and out and to check what is happening. The doctor comes for rounds, the specialist comes for rounds, every other person is there checking, monitoring, and evaluating the patient every day. Nobody is with you. You are alone. And we need somebody that can pay attention to the patient and give in everything they have, because they are the primary and everything of that patient at that moment. Do you understand? Next, I indicated that if you fail, you will be given to the mercies of the administration to decide if they will be sending you elsewhere and not to the family, the patient in the family's home. If the company does not have anything for you, they might send you back home. You were already told that in your interviews, correct? Correct. Okay. Now, when we now talk about what a community nurse is all about, the rules that the community nurse has to go, the 5 core competency that the community nurse has to respect, we will now be talking about what? The key principles that you must follow. And those key principles will be looking at one, respect for patient's autonomy. When we say respect for patient's autonomy, what do you understand by that? Yes. And?
We should not do that.
Sorry?
They should not show that rudeness to them.
Okay. Now you are a little bit not on what autonomy is all about. Now when they say respect for patient's autonomy, is what is autonomy to you?
Rights to control.
Exactly. You need to give the patient the opportunity to get involved in their own care. Though I want mama to eat fruit, high vegetables, drink a lot of water and all these things, I should still get up in the morning and ask mama which type of fruit she wants to eat. I will give her fruit, but then she will be the one to indicate the type of fruit she wants to eat. I want mama to take a lot of vegetables. Yes, mama is going to take a lot of vegetables, but I will still want to ask mama how she wants her vegetables to be prepared and which type of vegetables she wants to eat. So that I tell the cook, and the cook will make mama the type of vegetables she wants, and mama will eat. She will be happy. Unlike me just coming and telling the cook, I want mama to eat this type of vegetable today, off I go. No, this is not what we are looking at. We are not looking at imposing on the patient on what they should do or what they should not do. We are looking at giving them the lifestyle that is good for them and still allowing them to be inclusive in the care that we give them. Mama must bathe every day. Okay. But then mama should be able to tell you or choose when, at what time she wants to bathe. Mama will certainly take her medications, right? I should go before the time of medication to remind mama of the fact that she'll be taking her medication in 5 minutes time. Then I give the medication to mama and make her take it. Because if you are going to be caring for a patient that is suffering from dementia, she is certainly going to remember when she has to take medication, maybe before or after, and forget the fact that medication has been given and insist that you should give the medication again. You have to be able to talk your way in and out. You have to make sure that you can be able to convince the patient in time on what to do and how to do it in a nice, in a collaborative, and in a manner that the patient feels completely inclusive and they feel they have been given the powers to conduct this care in the best way possible. You must include the patient in access to their documents and to their medications and to their healthcare if it is needed. If your patient is healthy, if your patient can understand, if your patient can think, if your patient can speak, it is okay if she tells you, please, can you give me my medication sheet, or can you give me your report, let me see what you write. But if this patient is the one that probably the family is still trying to hide the fact that she is suffering from cancer, will you give the patient your medication file? But you will nicely tell the patient that it is out of her reach as per medical report or as per the family. And you as well, you will need to tell the family, you will need to give the family the right, the immediate family, the decision maker, the right to take certain decisions and to see the patient's medical file. Apart from that, no other person has the right to go to the patient's medical file, to their medication, and to whatsoever. If they must check anything, you have to check it for them, not them coming to your documents and checking it. Is that understood? And if they are welcome to check, or if they are welcome to see this patient medication, then they go ahead. That is if the person is the decision maker on that patient. Next, we'll be looking at professionalism and ethical obligation. The patient is bound by the Professional Code of Ethics, as such as the American Nursing Association of Ethics. So all your ethics, you should not do what, you should not do what, you should not do what, you must be able to respect all that. Did you study the American Code of Ethics yesterday? Oh, okay. If you did not see it yesterday, then we'll see it at some point in time today. Okay. Number 3, they need to know basics. Separate patient's information, share patient's information only to those that are concerned. The sharing of patient's information with me, of course, yes. With the hospital, with the physician, with the case manager, with the patient's nurse, with the wound care nurse, yes. With the pharmacy, because you need to collect medication, yes. Now, if you go to the patient's kitchen, probably it's your lunch time, you go to eat. Are you supposed to share the patient's information with the housekeepers, with the maid, with the cook? It has nothing to do with it. Do you go to the accommodation and you go to the kitchen to cook and you start sharing the patient's information there? It has nothing to do with them. Do you now take the patient's information and you put them on there? It has nothing to do with them. And there is what we are going to be talking about, the privacy and the confidentiality. It is one thing that when you breach, you have the right, or the nation has the right to send you for a lawsuit. Is that understood? Next, information consent. Obtain patient's consent before sharing information unless it is required by law. If a family member comes home and they tell you, I am mama's son, you've never seen the person before, and they are requesting for documents, do you share it? No, I don't know you, I've never seen you. Do I need to be rude about it? No. I simply will tell the person, if mama is the one that can speak, I will take mama's permission to be able to share. If she says yes, go ahead, it's my son. No problem. If I've never seen him, mama cannot speak, then I will need to take permission from the decision maker. If the decision maker says yes, it's my brother, it's my sister, you can go ahead and feel free to talk with the person. Okay, but I need to tell that person not to take it to heart, that they should just give me 1 minute to confirm with the decision maker or with the family before we can go ahead, because of course I don't know them. Best practices, which will be the best practices? Secure handling of records. When I give you the patient's file with your medication PMRs, You will be given a cupboard in the patient's home where you can store this document. And when you are leaving, it is okay to store them in a locked cabinet. If this information are supposed to be in soft copies, the soft copy should be in a protected electronic system that has a passcode. Next, avoid unauthorized disclosure. As I said before, you cannot do handover. You cannot be discussing about the patient's condition in public places like elevator, in the hallway, in the kitchen. You don't just talk about the patient's condition. And even inside the patient's room, if they have family members that are visiting, friends, loved ones of the family that are visiting, and they're inside the patient's room and you have to do handover, you will simply ask them to give you a few seconds. It is your closing time, you need to do handover, and then you can leave before they come back in. You do not do that in front of the families and the loved ones simply because you want to leave. You have to ask them to give you a few seconds. Is that understood? Okay. Number 4, professional communication. Professional communication, one, when you do it, handover, your handover is communicated using ISPA, either to your care partner or to the other nurse, depending on the services that you're taking. Next, you must avoid sharing patients' information to media or to social media or to using other devices, as well as you must maintain patients' privacy at all moments, whether you're bathing, cleaning, giving patients medications, handing over or doing any job or any services at that moment that requires you to have ultimate privacy. You make sure you maintain that privacy at all times. Consequences if this is breached. What will happen if all what I have said is not respected? Because whether you like it or not, if you have to breach any of this, the family will call. Sometimes they don't call us to give the complaint of what you have done. Sometimes they will call PNS directly. They will give their complaint to the office, and the PNS will be the one to call us regarding to you. So at all moments, I am expecting you to be at your best professional attitude. Disciplinary action. Disciplinary action first, we will give you a warning letter. It could be verbal or it could be written. The first verbal warning letter will be given to you, indicating with corrections on what you should and what you should not do. The second will come with a written warning, indicating and well documented on what you have failed to do and what you should do, and your own statement with regards to what happened. Now, if you are found guilty, you might have sanctions that will be given to you by the company. It depends on what type of sanctions you feel best. You might lose your license if it is in a case where we have negligence, we have abuse to the patient. You might be detained. Of course, if there is abuse to certain levels, if there is negligence, if there is assault, you certainly will be going to jail. Next, legal penalties. Then there will be a lawsuit against you, and if the lawsuit against you and the situation is bad, there will be termination and there will be deportation. This now will be done by the law of Qatar, not the company anymore, because when you happen to do something that the law takes its course, you have been given to the law. That is the highest authority. So we have nothing again to play in that. Next, when you start working with the patient, the first thing you start doing is try to gain their trust, is try to make sure that the relationship you have with the patient and the family is good enough for them to trust you with their patient. But if you start misbehaving, you will damage the relationship you have with the patient, and they will not trust you good enough. Is that understood? Okay. Special notes. And the first special note I want you to know is the fact that for every home, whether you see it or not, there is a CCTV camera. There is a CCTV camera, whether you know it or you don't know. And this is the family will be making sure that you are doing and caring for their family the best possible way. Of course, they don't know you. And they need to know you, and they need to see that all what you are doing is for the good of their mother, their father, or their child. And the CCTV camera is not there to prey on you. Because if you are doing a good job, if you are doing what you're supposed to do, you will not even pay attention on whether you have someone looking over your head. But if you go on duty and you spend your time with your phone, if you go on duty and you spend your time sleeping, if you go on duty and you are on calls out throughout the day, of course the CCTV camera will be a very good evidence to make sure that what you are doing is not right. As well as the CCTV camera is not just there to defend the family, it is equally there in case something happens and the investigation is going on. If let's say that you are with the patient and upon taking the patient off bed, there is an incident of a fall. It is not intentional. It is a fall. It can happen. And if this fall happens and we get a report of the fact that you were negligent and the patient had a fall, the CCTV camera is going to vindicate you to indicate that it was a normal duty that was going on and there was a fall. If there is a situation where the patient developed a bed sore and you are reported for negligence, you are reported for keeping the patient in long hours without change, we will have to use, during the investigation, the CCTV camera will be there to look at the activities you have been doing in that home, and if you actually change the patient after a long period of time, that is going to be enough evidence to prove. It is either going to prove either you're innocent or it's going to prove the fact that you did it. So you are supposed to do what you are supposed to do, when you are supposed to do it, and how best it is for you to do it. So we do not have to be checking CCTV camera to see what you did, whether it's right or wrong. Am I communicating? You are not supposed to use your phone on duty. In case there is an emergency, you call the hospital and you make arrangement for the hospital, for the ambulance to come get the patient. Of course, then you can use your phone. You can use your phone in a situation where you need to call the pharmacy to come get maybe an expired medication or request for a refill. As well as you can use your phone if there is a scenario or if there is something and I need to communicate with you and I call you, I should be seeing you using your phone at that time. If the family gives a complaint of the fact that you are always using your phone, I will need to use the CCTV camera to see you on a day and see that at every moment you are with your phone. Then it becomes a valid complaint. But if I have a picture of you with your phone in your hand, I will certainly not be able to identify if the time that phone was in your hand, it was because you were trying to call the hospital, it was because you were trying to call the pharmacy, or it was because we were trying to get to you. And during the day you are taking your initially day of admission, we are certainly going to tell the family that these moments you are permitted to use your phone to either talk to me, to talk to the hospital, to call an ambulance, to talk to the family in a situation where need be. But you are not supposed to remain on your phone. You are chatting all day, you are making calls all day, you are watching movies or you are on Facebook all day. No, your duty is to take care of your patient. Is that understood? So I should never report that you stay on your phone. Steps for referral. Now, what will happen or which steps you should use in a situation where there is an incident that has happened in the house and you need to refer the patient? Number one, you need to identify the reason for referral. And for you to identify the reason for your referral, that simply means you have applied your SOPI. What does it stand for? What does it stand for? What does it stand for? You don't know? F stands for what?
Situation.
No. F stands for subjective. And what is subjective data?
What patient is
What the patient has said. I have headache, I have leg pain, my back aches, I have fever, I have nausea. The things you cannot objectively measure. is the subjective data that has been given by the patient. And O, what does O stand for? The objective data. And what is the objective data?
What we are assessing.
What you have assessed. Now you have monitored the patient's BP, it is high. You have checked the sugar level, it is high. You've checked the temperature, it is high. So these are the objective data. You have used a scale, a pain scale, to identify that the patient has pain. Where did I press to? Forward or backward? You have used a pain scale to identify that the patient has pain. This becomes what? An objective data. What can be measured? What you and 10 other nurses can identify or have the same result. Next, A. What does A stand for? A stands for assessment. Assessment is what you have done. The ABCs that you have done. The head-to-toe assessment that you have done to make sure that everything that you are trying to do and to gather all other information that will permit you to give what? A correct report. I can hear one of the voices. Bring it up. Okay. P stands for what?
Planning.
P stands for planning. If I have gotten the objective, the subjective data, I have gotten the objective data, I have gotten the assessment, I have done my complete assessment, I know what is wrong. What am I supposed to do now? The patient was losing consciousness. When I checked the blood glucose level, it was low or it was high. And then when I did my assessment, I realized every other signs and symptoms that agree to the fact that this patient is hypo or it is hyperglycemia. With my planning, what will I do? Either I am planning to give insulin or I am planning to give sugar level to balance the blood sugar level, and immediately the blood sugar level is within range, the patient's other signs and symptoms will go away. Now, I will come back to do what? I will come back to the interventions. The interventions is me already identifying what I will do, and then I do it. Next, evaluation. Evaluation, what will you be evaluating? You will be reassessing, making sure that the subjective and objective data is gone. Most often, when we are evaluating, we go to the objective data and we never check the subjective data. You must first of all ask Mama, how are you feeling now? Do you still have headache? Are you still having nausea? Are you still having loss of consciousness? Do you have blurred vision? Are you still feeling very hungry and thirsty even though you just eaten? You must ask all these questions, and you don't just go to checking the blood sugar level and forget to look at who is speaking. You must ask about Mama. Mama said she was having back pain, and you just gave some pain medication, and you just changed the positioning, and maybe you changed the diaper that was wet and soaked right up to its brain. You must go back to ask Mama, Mama, how are you feeling? When Mama says, I am okay and everything is okay, you check your objective data. Your objective data should now confirm what Mama is saying. Then you go now to do your complete assessment. This is you identifying the reason for referral. When you have now checked all these things, let's say that these patients are having difficulties in breathing. And when the patient has difficulty in breathing, you check the having difficulties in breathing, losing consciousness. You check the parameters. It says that what the oxygen saturation is at 86%. If the oxygen saturation is at 86%, you come now to do your assessment. You realize that the patient is having crackers. And the crackers, the patient, you will do assessment, the patient is having edema of the lymph, the face, and the lower abdomen. What are you supposed to do? It is an emergency crisis. What will I do? What will I be suspecting? Patient might be suffering from pulmonary edema. And because the patient might be suffering from pulmonary edema, have I identified the reason for referral? I should be referring my patient immediately. So the planning that I will have will be a referral. I will not be going anymore to intervention and re-evaluation because this will now be done in the hospital. What will be my immediate interventions for that case? Position 1, 2, oxygen administration. Positioning and oxygen administration. And then I save the patient and maintain the patient to be living. Then I send the patient to the hospital. Is that okay? Are you understanding what I'm saying? For you to identify what you need to do, you will use SOPI to identify. You use SOPI and identify what you're supposed to do. Next one, need for specialized care or diagnosis. If you identify that the patient is having problem with the abdomen, if you identify that maybe, say you're taking care of a pregnant woman, now what is happening is labor has set in. You will know that you're sending the patient into the maternity, right? So when I'm calling the patient, I am identifying that the patient is in labor. When they are coming, the team that will be coming will be the team that is prepared to receive the baby, whether on the road or when they get to the hospital. If I am calling the patient, I said, I am suspecting what? Pulmonary edema. When they are coming with everything that would be necessary to save that patient while the patient is at home or on the road. If I am calling to say that maybe this patient was on a tracheostomy and the tracheostomy has dislodged, when they are coming, they are preparing to either insert a tracheostomy or with ample bags and everything prepared to keep that patient alive until they get to the hospital. Do you understand? Yes. Next, you want the inability to manage the patient's condition with available resources. When I identify the specialty or what is wrong with the patient, I will know the next step is if I can manage the situation. Again, the first scenario, of course, you can manage the situation and you have the available resources to manage the situation. But the second example, you cannot manage the situation and you don't have the available resources to manage the situation, so you will send the patient to the emergency department. 1, emergency care is required. No, all these will be done using ISPA. When you want to now call the patient, when you want to call 999, you have been given the ISBA endorsement form on how you communicate. I identify my patient, I indicate the level of consciousness, I indicate the current, the nursing provision that is required, the ambulatory status of the patient. I will give the complete medical diagnosis, the medications that the patient is currently having, and everything that is required for you to be able to communicate clearly for the doctor, whoever is on the other side of the emergency line, to get and to come for you. 2, obtain patient's consent. When I have finished doing that, there is an emergency. If my patient can communicate, I'll tell the patient right now we are on our way to the hospital. If the patient cannot communicate, I will ask my care partner, call the family and tell the family there is a need to take the patient to the hospital and this is happening. And I will get to it. Provide information that will facilitate the hospital, including services available. If I was working with the baby, I should be taking my baby to see them. If I am working with an adult, I should be taking the adult to Hamlet. Are you understanding this? Next, okay, for an example, if the nurse, in charge of the baby and is feeling the baby's well, you will transfer the baby to Sita, it's okay. And for the information that you have to be sharing, before you go, we will always give you the patient's medication form, and you should be going with the patient's medication form to the hospital. Identify an appropriate facility, which I said if it is baby, we have Sidra, and if it is an adult, we have Hamad. And you should consider the preference and the insurance coverage for the patient. If this is something that the patient can pay for, you should always talk with the family to be sure that the services that will be rendered to them, they cover it. The hospital is the one to cover it, or the insurance is the one to cover it. Next, prepare the medication and transfer medical record, of course, and the medical record here will be considered what? the medication history, the treatment plans, and the recent test result of the patient, the medication and non or unknown allergies. Insurance records are securely transferred to the patient, to the hospital. It is either you're going with them or you're not going with them, but make sure that the patient's medical record is insured. 5, communicate with the receiving facility via ISPA. Everything, communication, you must do it via ISPA. Coordinate with transportation in case where you have to take the patient to the hospital. Let's say it is a situation of an appointment. Then you have to coordinate for transportation by talking with the decision maker. Are we going to go through an ambulance or we are going to go by car? If it is the family that is going to provide you the car, good and fine, they will provide it and you make all the arrangement on that day you go to the hospital. If there is no car and you have to go by an ambulance, you need to book for that ambulance on the day that you will go in and the time, and make sure that when the ambulance comes, you are ready and prepared to move. Next, accompany the patient if it is necessary and provide clear instructions if you will not be accompanying that patient. Number 7, you follow up. Follow up means that, well, number 1, you address any additional concerns of patients. It means when you go to the hospital, you should make sure that each and every concern that you have has been covered. If there is questions on how to move forward, you should ask. You don't take the patient from the hospital, then you go home, and then you don't know what you are supposed to do with the patient when you get home, or how best you are supposed to care for that patient from that moment. Next, make sure that the reason for referral was addressed. If you were sending the patient to the hospital because of pulmonary edema, make sure that particular reason is or has been addressed. If you are sending the patient to the hospital because of something different, or maybe because of a fall, a severe fall that has a knock to the head, make sure that that particular thing, that problem is solved. If it is not solved, what next? Okay. Next, make sure to find out if the problem is going to be a long term or a short term. And if it is a long term, to when? If it is a short term, until when? Follow up with me. If you go to the hospital, that will mean that you are having a regular endorsement for that day and you have an appointment endorsement. If you can join your appointment and your regular endorsement and give in the same report, it's okay. You just need to indicate regular stroke appointment. From the title, I know already that this is a combination of a regular and an appointment. That is in a case where there is an appointment. If it is an incident that occurred, you write regular stroke and incident report, and you manage them the way it's supposed to be. Next, in the situation where the patient is admitted in the hospital, if the patient is admitted in the hospital for the medical ward, your services, you will not be going on duty. You wait for the days that the patient is in the hospital. 1, 2, 3, 4, the patient is still in the hospital, no problem. You will be there, just waiting. When it gets to the 10th day, the services from the 11th day will hold automatically. And when we hold the service, we will now use you as a reliever for other patients until this patient has been discharged. They will go back to PMS and reinitiate their services, and then you go back to them. In case the patient is admitted in the ICU, your services will be held from that day. That very day that the patient is admitted in the ICU, that day I will indicate that the patient has been admitted and is in the ICU. The next day we hold that service and you'll be used as a reliever for another patient until a number of time. If up to 3 months that patient has still not been discharged, the services will automatically stop and you'll be given a new patient. Okay? But for the time when your services have not been held, you will be paid normally. So if it is in the medical ward and you have to have 10 days you are not working because the patient is in the hospital, those 10 days, they are completely paid. From the 11th day, the services will be held and you'll be used as a reliever. So you'll be paid for the relieving. If you are an ICU, If the patient is admitted in the ICU, the services will be held immediately and we will start using you for a reliever, but we will not give you a permanent patient. And after 3 months, if the patient is still not being discharged, the services will stop and we will give you a new patient. Is that understood? Okay. As for now, do you now understand who you are as a community nurse, what you should be doing, what you should not be doing, the rules you must respect, the situation you will face, the services that you'll be rendering, or the types of services that is being rendered, and what you are supposed to do? Do you have a question for me? You understand exactly all this is all about? Okay.
If we are shifting the patient to hospital, we are endorsing there. From there, we no need to stay there.
Yes. Now, the call that you are going to make using SOPE is the same call that will go with it and to work. That is why your ISBA must be clear, coherent, and straightforward. When you take the patient from home and you get to the hospital, you hand the patient to the medical team and they'll take it from there. You come back home. Is that understood? In some situations, they might want you to stay for at least 3 days with the patient in the hospital. That is still fine. After those 3 days, they will ask you to go home. Okay? In some situations, they will ask you to go home immediately. Now, when they evaluate the situation, they realize that it will be a short leave because some patients they will come in, everything will be finished, and then they'll go back home. But if they realize that it's going to take a little bit of time, they will ask you to go home. And we will wait for the 10 days to hope that the patient is discharged. Is that understood?
Yes.
Okay. So thank you so very much. Here we have analyzed to you what a home community nurse is all about, what you are supposed to do, what you're not supposed to do, and how you manage and handle situations that comes in contact with you as a community nurse. Thank you so very much. If you are joining us for the first time, I'm Nurse Aisha, and here live in Qatar. Thank you so very much. Ciao. You can go for break.